All right, board questions. Yay, board questions. Dude, this is like my default content at this point. A 30-year-old woman comes to the office due to a nodule in the right lobe of the thyroid gland. The nodule was discovered incidentally on a CT scan of the neck performed 2 weeks ago to evaluate neck pain following a motor vehicle collision. So when they say incidentally like this, like, honestly, this is where I kind of disagree with like concierge medicine or, you know, those full body scans that they do in, I know this is super popular in Korea because my dad was like trying to tell my mom to do it, but they do like whole body MRIs like every year or something, and you pay like $2,000 and you just get a full scan of everything in your body. And it's like, why? Right? Like, if you feel in pain or if you feel like something's wrong, fine, get it scanned. But like, what is the point of subjecting yourself to these stupid yearly baseline scans for the chance that something could be wrong, right? And then it's like, you find something incidentally, you're going to have to follow up on it. And if you were asymptomatic the whole time, what does that cost you in terms of money, you know, the hardship, emotional turmoil, everything? Ugh. What is a nodule? A nodule is just like a solid bit. Like, just, you know, it could be like a cyst, it could be a mass. It's just something that you find on a scan and you're not really sure what it is. Without a biopsy, you're technically not really sure what it is. All right, so she found a thyroid nodule on her right lobe. She incidentally had a CT scan performed 2 weeks ago to evaluate neck pain following a motor vehicle collision. The patient feels well and has experienced no weight change, temperature intolerance, hair or skin changes, or menstrual irregularities. So it's not super hot, right? It's not like it's secreting T4 straight up immediately. She has no chronic medical problems, takes no prescription medications, and has no history of radiation exposure. Family history is negative for thyroid cancer. The patient does not use tobacco, alcohol, or illicit drugs. Blood pressure is 120/80, pulse is 72. Thyroid examination reveals a palpable, firm 2-centimeter nodule on the right lobe. Neck lymph nodes are not enlarged. Remainder of the physical exam is normal. So despite despite the imaging, you have to cut and open or do nothing, right? So this one probably is a question of, do you know how to manage nodules? Like, whether you discover something, if it's active or not, what are the criteria where you actually need to do follow-up testing, or if you need to do nothing. So one of these is probably just, yeah. So like this one, repeat TSH level in 3 to 4 weeks. That's like the do nothing and reassure option. And then I'm pretty sure for low thyroid scintigraphy is what you're supposed to do next, because yeah, this entire clinical vignette, it's an incidentally discovered thyroid nodule. The patient is totally fine. She has no history of thyroid cancer. She has negative on all of these hyperthyroid syndromes, no chronic medical problems. She's 30, she has nothing else going on, right? And she doesn't seem to have any other complaints coming in, but the ultrasound shows a right lobe hyperechoic nodule, measuring that with no evidence of microcalcification or internal vascularity. What is the next best step in the evaluation of this patient? So there is a whole, you know, like algorithm to manage thyroid nodules. But unfortunately for her, even though her free T4 is normal, her TSH is still low. So unknown bioboulder. Yeah, unknown bioboulder is actually a pretty good way to explain it, because you don't know what it is, right? Yes, we can do an aspiration. We can stick a needle in there and figure out what it is right now, but do we need to, right? I'm pretty sure it'll show like the full, you know, algorithm or flow chart once you actually get to the answer. But for this patient, because she's totally fine, you might want to think that you just repeat the TSH level and you have to do nothing. But because her TSH level is low, even though her free T4 is normal, I'm still worried that you're still going to need to work this up. Your thyroid gland is basically the gland that controls the on-off switch in your body. High thyroid means that, you know, you're constantly awake, you're constantly up, your heart rate is going 1,000,000 miles an hour, you're sweating, all these things. Low thyroid is you're lethargic, you're swelling up, you sleep like 20 hours a day, depression, brittle hair, all these things. So having a good balance of thyroid is also very important, and this is like an endocrine organ that a lot of people overlook when they're doing these initial workups. But things like on the differential for a blood pressure problem, always got to think about the thyroid. Things on the differential for like a psychiatric problem like depression, always got to think about the thyroid too. So the thyroid stimulating hormone comes from your pituitary gland, and your thyroid stimulating hormone is secreted when your pituitary gland gets your signals from the hypothalamus that's telling you to make TSH. TSH is going to go to the thyroid and make thyroid hormone, and high levels of thyroid hormone finish a negative feedback loop telling the pituitary, hey, you don't need to make any more thyroid stimulating hormone, you're good. Now the problem is the patient has a high T4 level, which is, or a normal T4 level, but even though they have normal T4 levels, their TSH levels are very low. So the TSH means that the pituitary is getting some sort of negative feedback from somewhere that's telling it, hey, you don't need to make as much thyroid hormone. And because the TSH is low, you would expect the T4 to be low, but it's not. The T4 is normal. So there is something going on here that's causing a wrench in this negative feedback loop where these things aren't adding up. And because she does have a nodule, you're going to have to work this up with scintigraphy. Nice. Actually, yeah. So this is pretty good too, because this one looked pretty split. Half of the people picked scintigraphy and half the people picked FNA, because you actually, yes, eventually you're going to have to, but it depends if this is an active problem or not. A 40-year-old woman is referred for the evaluation of chronic kidney disease. She has a 2-year history of intermittent back, bilateral flank, and central abdominal pain. Okay. She has lost approximately 15 pounds and is easily fatigued. Okay, whoa. She had an episode of DVT 1 year ago that has not reoccurred, and she has noticed bilateral pedal edema. All right, so she's got back pain, abdominal pain. We already know that she has CKD. So she has some kidney issues where her kidneys are not excreting, waste products as well as they could. Maybe they're not filtering as well as they could, not reabsorbing fluid as well as they could. That's why she's swelling up a little bit. She had a couple other problems. She had a blood clot at one point. She lost 15 pounds and is easily fatigued. I don't know, did she lose 15 pounds in 2 years or like 15 pounds in like a week? She works in an office, denies using tobacco or illicit drugs. Up until 2 years ago, she felt well and is unaware of any chronic medical problems. So 2 years ago, this all really started happening, and she had this back flank abdominal pain, and really she's kind of managing it with Tylenol and Advil, but it seems like her kidney disease made things worse, and she's now having diffuse mild abdominal tenderness and lower extremity edema. Okay, this is a lot. So CBC, hematocrit's fine, leukocyte's fine. So creatinine's 2.2, she has CKD, we already know that. Urinalysis, she's not spilling protein or blood. She doesn't look like she has a UTI, but she's some red blood cells, some leukocytes. She's got pretty decent inflammation, acute and chronic. On renal ultrasounds, both kidneys measure 12.5, so they are a little bit bigger than they should be. There's bilateral clubbing and mild to moderate dilation of the calyces without dilation of the mid or distal ureters. So she has dilation of the renal calyx, or that's part of like the little pyramids that empty into the renal pelvis, without dilation of the mid or distal ureter. So it's not really a kidney stone, right? And it's not like things are backing up. It's more just like the interstitial tissue in the kidneys themselves are squeezing against the calyces, maybe? B or C? I kind of like C. I don't know. Like, this is such a zebra diagnosis, but this is the only one that really explains everything. Maybe you can say cervical cancer. B and C talk about her kidney issues 100%, but they don't talk about the amount of pain, weight loss, and the fact that she had a DVT a year ago. What I think this is retroperitoneal fibrosis, and this is something that I only know because my nickname for Hero on Discord is retroperitoneal fibrosis. Retroperitoneal fibrosis is a consequence of IgG4 disease, and is something that can also be associated with chronic pancreatitis. I think her back pain, her central abdominal pain, her weight loss, and her DVT, and honestly, even a little bit of the pedal edema is explained by RPF, and she also has CKD, and all of this is just her CKD. Right? CKD is not going to cause your CRP and your ESR to be that elevated. CKD isn't going to cause that amount of central abdominal pain. CKD isn't going to give you 15 pounds of weight loss, right? So I think this is just IgG4 disease. I don't have a good reason to say that it's not cervical cancer because like, what if it is cervical cancer, right? Because it's cancer. I think like at the end of the day, I'm just trying to say that this is like an inflammatory process with like multiple organ involvement. But I think our PF is like screaming a lot more. Oh, 44%. Okay, yeah, 25% of people said it was cervical cancer was spread into the broad ligament. So this definitely like was a thing on people's differentials. Why does RPF cause weight loss? I mean, because you're basically just in the setting of constant inflammation and malignancy. It's like pancreatic cancer, right? You're just going to start like wasting away and stuff. Patient's presentation is most consistent with retroperitoneal fibrosis, a rare disorder causing mid and distal ureteral obstruction without the usual ureteric dilation seen in obstructive uropathy. So obstructive uropathy, that's what I was saying. It probably is not a kidney stone or something obstructive because the actual ureters aren't dilated. RPF is usually idiopathic, but has been associated with drugs, malignancy, infections, and radiation therapy. RPF is the result of chronic inflammation with fibroblast proliferation leading to chronic periaortitis and involvement of surrounding structures. So yeah, that's really what I was saying with, you know, why she's so inflamed, why she's losing so much weight, where all this pain is coming from, etc., etc. 46-year-old man with known Kyphoscoliosis. Okay, so his spine is like bent forward. What is it? Hunchback. There we go. Complains of fatigue and progressive shortness of breath over the last year. He can barely walk a block without becoming short-winded. During his last evaluation, his vital capacity was 40% of predicted value, and his FEV1 FVC ratio was 85%. So yeah, there are lung diseases like COPD or, you know, pulmonary fibrosis, and then there are actual like mechanical diseases like severe kyphoscoliosis, which is hunchback, or lordosis, which is like swayback, and this is literally just like the actual physical chest space that your lungs have is not enough to adequately expand your lung tissue and all these things. Patient's blood pressure is a little high, but it's okay. Oxygen saturation is 90% on room air. The angle of scoliosis is 65 degrees, and kyphosis deformity is above T10. Yeah, so it's definitely, you know, it's definitely getting his ribs. Angle of scoliosis, I don't think there's a number for kypho. I know for like scoliosis, like normal, like when you're doing like pediatric screening and like teenagers and stuff, they monitor something called like the Cobb angle, which is like the perpendicular intersection of like the spine and like the largest deviation from the center. And that's what they measure, but I think angle of scoliosis in this case is mostly just talking about the front to back angle. Transthoracic echocardiogram shows normal LV function, mild right ventricular enlargement, and an estimated pulmonary artery systolic pressure of 55. Okay, so he's got some right-sided heart failure, or at least right-sided heart problems, based on the fact that his pulmonary vasculature is not flowing through correctly because he has so much chronic pulmonary disease. But it's not really COPD or something from like smoking. It's really just like a mechanical problem. So, I mean, I think somebody said it already earlier, but I would probably just go with intermittent non-invasive ventilation here. I don't think inhaled corticosteroids are going to help this guy because it's not really an inflammatory problem. Long-term anticoagulation, I mean, it's not really a clot problem. Like, he doesn't really have a clot burden either. It's all mechanical, right? Like, you know, if this guy did not have this severe kyphoscoliosis, he probably would not have these problems, but his back and his current like angle of scoliosis is really what's driving most of these problems. Yeah, so it's alveolar hypoventilation, and you would fix that with intermittent ventilation, right? So you wouldn't need to give him vasodilators or corticosteroids. You wouldn't need to give him anticoagulation in this case because you can just fix it by fixing the mismatch here. Bracing is interesting. I'm pretty sure you're not supposed to do bracing. Yeah, bracing may be used in idiopathic scoliosis for skeletally immature adolescents, but is contraindicated in adults. I'm surprised 51% of people pick that, because that's you're not supposed to do that in adults. 33-year-old man comes to the emergency department due to a 2-day history of left knee pain and swelling. The patient has not had similar symptoms before and reports no preceding trauma, pain in other joints, skin, rash, fever, or chills. So we got left knee pain and swelling. Could be like a reactive arthritis. He's 33, maybe he's sexually active, gonococcal arthritis, etc. Med history is only notable for seasonal allergies, which he takes loratadine as needed. So patient does not use tobacco, alcohol, or illicit drugs, so otherwise pretty healthy. Temperature is 98 degrees, blood pressure is 110/56, pulse is 78, respiration is 14, BMI is 22, so he's totally fine. But his physical exam is a moderate left knee effusion. It's slightly worn, but it's not erythematous, so it's not really super red or swollen, and there's no locking of the joint or ligamentous laxity, so it's not like a meniscal or ACL kind of tear or anything. Labs look fine. Okay. I think, what is a normal ESR? I think his ESR is fine. 0 to 15? Oh, okay. So ESR is slightly elevated. So he's got some more chronic inflammation over the past 2 days. X-ray of the left knee reveals linear calcifications of the menisci and articular cartilage with moderate effusion but no fracture. So he has calcifications. So now I'm thinking more of like a gout, pseudogout kind of angle. Ooh, okay. Synovial fluid analysis shows leukocyte count of 15K with 80 neutrophils. Gram stain shows no organisms. Crystal analysis is pending. Boo, the lab should have done crystals by now. This is it iron studies? I mean, we have the diagnosis, but it's like, which of the following of the most additional tests is most appropriate to evaluate? That's so stupid. It's not anti-CCP because it's rheumatoid arthritis, ANA, double-stranded DNA, HLA-B27 testing. So this is going to be for ankylosing spondy. This is going to be for like lupus, and this one's going to be for rheumatoid arthritis. I'm going to say, right, like you would think that uric acid level corresponds with gout versus not gout, but I don't think it's uric acid level. I think it, yes, hemochromatosis. I was just about to say that. I think you do the iron studies first before you figure out why they have pseudogout. Yeah, it's hemochromatosis that causes them to reduce clearance of CPBD crystals, and that causes them to deposit in the joints. So serum uric acid level was like the second most popular one, definitely. Uric acid levels should not be drawn during an acute attack, as they might be misleadingly normal. So this one is more of an inflammatory arthritis, but it's an inflammatory arthritis associated with the fact that he has calcium pyrophosphate crystals depositing in the thing. 40-year-old man comes to the office due to sleep difficulties over the past 2 years. He regularly goes to bed at 11, but is unable to fall asleep until 12:30, so that's like an hour and a half. As bedtime approaches, he typically becomes tense, watches the clock, and worries about the prospect of another sleepless night. The patient eventually falls asleep and awakens by alarm by 6 a.m. in order to arrive at his office by 8 a.m. During the day, he feels fatigued and is concerned that his insomnia is negatively affecting his work performance. The patient does not take naps during the day. His wife has not noticed any snoring, unusual limb movements during sleep. General health has been good and he takes some medications. He would like to exercise, but he feels too tired. Okay, so this is really a sleep hygiene question, but it's like a very esoteric sleep hygiene question because it's not like the normal ones. Maybe it's almost like an anxiety kind of thing, right? Like as bedtime approaches, he typically becomes tense, watches the clock, and worries about the prospect of another sleepless night. Okay, so I mean, it's never napping. Recommending restricting time in bed to 5-6 hours a night. I mean, he already spends like 6 hours and 6 hours a night in bed anyway. Recommend going to bed only when feeling sleepy. I mean, this is pretty valid too, right? Like if you're tired, go to bed, and if you're not tired, not go to bed. I think it's psychophysiological insomnia because of the maladaptive association and conditioned anxiety. Yeah, right. The conditioned anxiety with the watching the clock and worries about the prospect of another sleepless night, like this part makes me think it's like something psych related more than just sleep hygiene. But I feel like recommend aerobic exercise before going to bed. I mean, it makes you sleepy, I guess. Advise remaining in bed, doing a relaxing activity even if unable to sleep. Is a relaxing activity good enough to treat this sort of anxiety? I don't know. No, I feel like isn't it almost just like you're not supposed to be in bed, right? Like you should associate, like that's the thing that they always teach you in college, right? Bed is for sleep and for sex, and that's it, right? Because if you like do your homework in bed, or if you watch TV in bed, you associate being in bed with not being sleepy because you're doing an activity in there. Dude, this is so stupid. I don't know. I know what the diagnosis is. I just don't know what this question wants from me. Aerobic exercise before going to bed, I feel like is such a trap, because I think the correct recommendation is like you need to do the exercise like an hour before you get ready for bed or something. Like it's not going to bed, it's before you get ready for bed. So I think it's D, honestly, because I think it's like you only go to bed when you're sleepy, and if you're sleepy, you'll fall asleep. But if you stay in bed, you're going to get tense and watch the clock and worry that you're not getting enough sleep. So that's why you shouldn't stay in bed doing an activity even if you can't sleep. But then recommending restricting time to 5-6 hours a night also feels like maybe he needs less than 5-6 hours a night, right? I don't know, because he has to get up at 6 a.m., which makes him anxious, which is why he's not sleeping, because he's like, oh my god, I have to get up so early. So he tries to go to bed at 12, but he can't really, so I'm gonna say D. Okay, I didn't like the answer choices. Why can't you just give me like a normal sleep hygiene question? He's chronic insomnia from associated of the bed and bedroom with fear of not sleeping. Stimulus control, yeah, so you only go to bed when sleeping. Bed for sleep and sex only, exactly. That's what they taught me my freshman year in college. That's what I have to teach this patient.